part B of the board report. On item 52, nursing, midwifery and allied health professionals biannual staffing report. Where's that?
Not here, she's disappeared. Yes, she is. I know.
I'm sorry, it's a patient upstairs.
Come on, tell them.
Just introducing item 52, Tabitha, so
Biannual.
I'll get your breath. So we do have,
Sorry. Was lost.
we have a colleague here, Lorna Pitt. I thought, Tabitha, you could do the
Yep.
introductions.
Thank you very
So
much.
item 52 then, I'll pass the paper over to you and you can introduce Lorna to us.
Thank you very much. So this is our biannual safer staffing report, which is here for assurance in line with our quality board standards 2016, and Lorna will take us through that.
Thank you. Thank you very much for allowing me to present to you today in person. So I hope I can cover just a few of the highlights really for you from the paper. Obviously, this is the third set of data collection that we've done using the Safer Nursing Care tool and expanding that into some of our other collection tools which are noted in the paper. And as a result of those previous establishment reviews, we've had an increase of 220 registered nurses, whole-time equivalents within our establishments. And as part of that work, obviously vacancy and the management of that has been a challenge as the establishments have grown throughout that period of time. This paper asks for a very small whole-time equivalent ask within the surgical care group, which they have identified the funding for. So there's no additional financial requests within this paper and no other additional requests for establishments. I think what's positive really was from the professional judgment meetings that were happening with all of the managers of the departments. The feelings were very much that they had the right establishments to deliver their services, and we're working towards controlling that vacancy rate within them. That was very promising. I think the other positive notes are around the vacancy rates, absence rates and turnover rates within nursing and midwifery. All are on an improving trajectory at the moment. I think that's very good to note. And then obviously we just have put some forecasting in there around how we'll try and maintain that matching of establishment for the next sort of couple of years. Our plans around recruitment for international recruitment projects that we're covering, around 174 nurses in the last 12 months. So a really significant programme of recruitment, and also our apprenticeship programme, which sees 20 nurses, either nurse associate or registered degree nurse apprentices coming into the organisation twice a year, so 40 in total. And the new NHS long-term workforce plan is obviously asking for an increase in that model of recruitment. So it's positive to see that we're already kind of making steps towards achieving that. I think that's my highlights.
It's a substantive report. Comments or questions, Adrian?
Thanks, Chair. Thanks for the report. It's really, really interesting. One of the areas that I just wanted to focus on was about community care and community-based provision, really. And I've just got a few comments to just copy. Let's just work this one through. I recognise that for the future transformation of health, we need to lean more heavily on community services. But this assessment is about safe staffing, isn't it? And I feel that they're slightly different in terms of their, the basis that those numbers are assessed at. I recognise that the community services, they're just going through this process for almost the first time. And I'm also aware that if we don't have enough community services, then managing outpatients with those packages of support, particularly where we're trying to ensure that people can leave the trust effectively and go back home with those packages of support, we need to have staff in place for that. So I was just wondering, in terms of those winter pressures emerging, how quickly are we going to see this review completed so that we understand the uplift that's required in terms of our district nurses, and can we get that enacted before the winter pressures emerge? And then secondly, going back to that same staffing conversation, are we looking at developing more capacity in our community-based services to support those packages of support and address things like demand mitigation, so there are a few people coming through the door because we're managing services and we're not allowing managing conditions and not allowing them to escalate. Does that make sense?
So
I know there's a lot in there.
I'll let you come through in terms of what's happening, and then I can add in terms of what's happening across the ICB around community.
Yeah, so the staffing community services use a slightly different model to understand their establishments. It's called a CNSST tool. So it's Community Nurses Safe Staffing Tool. They've completed some data collection in the last 6 months. They're using a model of more semi-continuous data collection, so they're doing more frequent data collection. At this stage, the tools haven't identified any significant requirements in terms of uplift, but what we're conscious about really is their vacancy rates are more of an exception to the rule around improvement. They have got more challenging vacancy rates. So I think their ambition was to try and establish to their current establishment before they started to look at whether they would want to build on that establishment in the future.
So are we able to improve the level of bill rate and reduce the vacancies? I'm particularly mindful about winter pressures emerging. Have we got a plan to do that? Immediate period.
So from an international recruitment perspective, that is one of the big challenges for community services, because people need to be able to drive and have access to vehicles. So that's proven a challenge nationally around how we would use that pipeline to support them. So they are more reliant on our conventional recruitment methods, so apprenticeship programs and standardised sort of standard student recruitment. So they capitalise on that more than the other care groups. But we are looking at how we might do some focused work to recruit internationally for community services as well in the future.
Well, thank you.
Thank you, Chair. Just to support what Lorna has just outlined, there is a community services transformational board that's just started, which is looking at how to support community pathways as well as staffing for our community work. So some of the work and the reviews that Lorna is referring to is going to be supported through that community transformation, because there is actually a workforce stream from the transformation board. So there's a bit more work in the community which involves the safer staffing that Lorna is talking about there too. There's also about pathways, and there's also how we work as an integrated system to support the whole system flow of the program and reduce the implications. So we can update as required.
Thank you.
Progress of that.
I really look forward to an update through the People Committee about that particularly. Thank you.
There's only a couple of levels of either reassurance or assurance for the board. So Ali mentioned earlier under the IPR about each care group being tasked with producing its workforce plan based on the safe staffing and the clinical strategy development. So that will feature as part of the community focused kind of recruitment plans for their own workforce requirements. Tabitha's mentioned the winter plan and the urgent care kind of whole system flow programme. So resilience and assurance to board under our normal oversight processes to say how we fixed for winter. That will feature as part of the capacity assurance or otherwise for the winter plan. And the third bit is just a word of a reflection and caution. We have as an organisation put a lot of investment into things like community services, community teams, discharge to a hospital discharge. They are costs that we incur for services and infrastructure that I think are best placed in other partners. And the community service transformation programme is designed to start to look at that. So whilst it's right and proper, we look at our community structure, vacancy that we have in a workforce that gives us resilience. I am cautious about additional investments and pushing into supporting services that actually there are other partners in our system that have a responsibility. So we just need to be cautious about inflating our cost base. And actually, there's a requirement for the Community Services Transformation Programme to put in place. We need to make sure that's in place. That's obviously not for the things that we're accountable for, responsible for. That's not.
May I come back to that point, Chair, if I may? I mean, what you described there, there's clearly a term of investment and demand mitigation and supporting people well within their communities, which don't increase the cost base for the trust. Do we understand that level of commitment that we're able to give to community services, so that we're quite clear about the threshold as you describe it, don't go beyond that?
No, there isn't a return of that type that would give us that confidence, Adrian. It's the benefits are seen elsewhere and the costs sit with in terms of the not meeting criteria to reside or the delayed levels of discharge. Risk mitigation on a quality and safety perspective rather than a return on investment. So we did do some of that, putting the case together for the investments in this area, but was viewed on balance of risk that was going to support the investments at that time. We're going to have to get a bit more gritty and professional about accepting either risk or pushing more investments right parts of the system. I'll be encouraging the exec team when we pull these proposals together to have that balance of risk narrative rather than people commit to a finance committee on investment.
That's good to know. Thank you.
Karen?
Thank you. Thanks for the report, Lorna. It's really just really helpful to see it set out in this way. I'm just really got a question about maternity services, so particularly page 143 of the pack. And I'm aware that there's a workforce review of maternity that's been undertaken with regional colleagues, and there's an options appraisal in response to that in the pipeline. So I just wondered whether once that review has and options have been completed, whether in future safe staffing reports we'll see maternity and midwifery services as part of it. I understand why it might be separate at the moment.
Yes, we would, Karen, is the simple answer.
Okay, so it's just simply that review is underway separately and they need to be brought together going forward.
Yeah, I think the review has been done separate at the moment because of some of the national oversight and things like that. But I would like to see maternity as part of the whole nursing midwifery AHP workforce.
Okay, thank you. I thought that was the case, just checking. Thank you.
Gary Barney?
Chair, I'll use my newness to ask this question. But in relation to international recruitment, do we have a robust process of making sure people are integrated into the system? You know, we did talk about NHS being unique in that regard, so that people are introduced into the systems and how it works in this country, and also making sure people are well integrated within the community, and wherever they go, we kind of have that support system for them to feel like they've come home, rather than this is going to be a strange place with all the strange systems that they'll be using.
I can assure you we do. And we can still strengthen. We still have issues, obviously, around our international nurses in terms of pure integration, because they have to be supported. They have to sometimes be trained to work to our policies and procedures. They have to be nurtured, accommodated. So we have got things around in place. Saying that, the bits where we can do better in terms of like how our culture within the organization, how receptive we are to the international recruitment. So we're working on that to improve that. I think Lorna can say from somebody who's been here longer than me, if I've left out something we're doing.
Just really to sing the praises of the clinical onboarding team. We're a really small team that I look after, and they work really hard to look after the international nurses and hopefully other international recruits in the future. They help them with all of the kind of pastoral stuff as well as the practical how to work in the NHS. but also help them with, how to get accommodation, how do you get a bank account, where do you go for, what clubs are around, what social activities. And also Alma Paula, who's from Ali's team, works really well with the whole retention strategy around international recruitment, just again, looking at the wider picture of how they feel part of organisation.
So just to kind of provide a little bit of independent objective assessment that comes into this, we were one of, I think, the first trust to receive the pastoral care accreditation for our international recruitment programs. So that's obviously independently and objectively assessed, so that I think that can give us some assurance around the kind of level of support that's in place for our recruits that come from overseas.
Okay, and if you want some reassurance, you can follow Alma on Twitter, and she regularly updates on activities and how the international recruits are feeling. It's really good actually to see them.
And we can invite you when we welcome them when they arrive. If you're welcome to come join us, meet them.
No,
some
not
of them.
that, yes. Yeah. Need a cake.
Colleagues, a quick point from me. This obviously refers to the end of last year's financial year, so it's up to the end of March. Some interesting triangulation though, based on the data we had this morning. You pinpointed some of the care areas which is below the 85% fill rate. You then, I think, very nicely triangulated that with acuity and hotspots, particularly around falls, etc. AMU, for instance, is highlighted in the report. And then you can triangulate through the report the cost of agency and bank staff, which was about £16.5 million last year. Interestingly, medicine is the highest cost for both bank and agency, though not surprising. My question really is, are we going to have areas of priority where we say, right, these areas are consistently not recruiting? So do we prioritise those areas, particularly around frailty, older people, that area? Or are we just going to take a blanket approach of, well, we're just recruiting to staffing numbers to complement, rather than go, actually, no, we need a focused recruitment drive for these particular areas, because that's what the report seems to say to me, that some wards have above 85 staffing rate, which is great, and they have a lower issues with acuity, which would be sensible, but also have a lower staff and agency cost, which again you would expect. As some of the execs triangulating this to say where's the key areas for targets with a time scale.
I could sort of say we're doing it through our performance assurance framework. And when we talk about workforce and bank and agency, so we prioritize those. So medicine is one of them.
I'm not sure it's working, Tabitha, because midwifery, I've been here 3 years, it's always been understaffed. So we've always had difficulty. Now, I know it's a national picture, but medicine, for instance, older, frail people, medical care, and that, we've got vacancies. We've never recruited in 3 years I've been here.
So this is the piece of work that I was referring to in terms of taking a focused effort around prioritising the areas where we've got workforce fragility, whether that be now or whether we're expecting it because of the age profile. And that's why we've said end of July to get some plans around what's the workforce redesign, what's the recruitment targeted approach, what's the service redesign. We can't fill that in a sustainable way. And that's going to pick up both from all staff groups perspective. So it will pick up from particularly around the areas of the high cost medical agency spend. We talked about that quite significantly, where that I think it's fair to say that the plans need development and further refinement. They're in very, very early stages that necessarily don't have the level of confidence that we would want at this point in time. But as we move forward with this planning process, I think we'll get to a more robust point and we can take that into people committee.
What's behind my question really for the execs, except there are statutory requirements for some roles, like a midwife has to be a midwife. But in other areas, if you look at the NHS workforce planning paper that came out, and it's actually out today, isn't it? It talks about allowing existing staff to do different roles, and I'm just, because rather than go, well, yeah, we've always had a vacancy there, but we can't fill it. We go, well, let's not keep flogging a dead horse and look for a different way of dealing with that stuff.
So just that has been, and I think the paper that Lorna's put together here shows very much the expansion of advanced clinical practitioners, and that's not necessarily nurses. It could be healthcare scientists, or it could be AHPs or midwives who are in those advanced clinical practitioner roles. But we've got to be careful because there are, we have already done quite a lot of this, and we need to be careful around the not diluting the skill mix too much from a medical perspective. So that is the piece of work, and but I think we probably have more to do, particularly the long-term workforce plan talks very much around the expansion of the physician associates and the nursing associates, and that could be somewhere where we look to explore further compared to.
It's just that sense of controlling the agenda. It's a good report, Lorna. I really enjoyed reading it. So easy to triangulate. And of course, then we've got the performance, and then you could do further cross checks. It's really interesting how things seem to form a pattern. It's just that sense of, you know, have we got a plan to control that, and what's our deadlines and timelines? When are we going to bring in these new types of workers? How soon would that be? And how that impacts on patients? Because at the end of this, there are people who are falling and they've got leg ulcers, particularly AMU, which is a red line across.
Just to kind of add to, really, I suppose the fill rates are impacted not just by the vacancies that we have, because we can have a fully established unit. It will then depend on the kind of demand in the fluctuation of staffing need, because the tool only kind of gives you a benchmark. But equally, there's something about rostering and the rostering efficiencies that we can bring in. Because if we haven't got it, if we've got lots of staff off sick, lots of people on holiday, we're never going to also fit our establishment, and that's where the fill rates drop. So we have got a check and balance process now where Dan and I meet with all of the ward managers, and we're expanding this into other teams to examine that roster efficiency, key performance within rostering, because if we get that right, it makes the best use of that establishment to achieve the fill rate that we need. So that's a big part of our issue, more than vacancy in a lot of places, is actually just making sure that the establishment then does what it should do to deliver.
That's a really good point. And there's an early suggestion of that in the paper on page 150 to 153, where it shows those fill rates and sickness rates. Really. Okay, we're asked to consider the proposed safe staffing review from all the care group and the resultant changes to staffing establishment, including the respective financial implications. Yep. Okay, and then consider the context of these requests in terms of fill rates, vacancy, sickness rates, staff turnover, etc. All the things we've just said, as highlighted in Appendix 1. Yeah. Lorna, thank you. I know you've been sitting there very patient watching the board. I hope you found it of use.
Thank you very much. Making notes.
Okay, accept the report. Thank you. Over to the Chief Exec now, working in partnership. Item 53, provide a collaborative update.
So the report there is there for review. I'll take the report as read, and I'll highlight two particular elements for board consideration. One is, at the last board, I highlighted that the Joint Committee and the Provider Collaborative Board had taken an agreement in principle on the Central Services Collaboration Workstream to create a target operating model under a hosted trust arrangement, centralised services, and then an operational delivery model that talks about what proportion of those services end up in a central delivery vehicle, how much of it is retained locally for delivery, with an ambition to create a central services way of working that's attractive to colleagues, provides some good quality career development opportunity, allows us to share and implement best practice across the provider collaborative, and release costs through productivity and efficiency. At the last joint committee, that was agreed as a proposal. We will now be working through the arrangements for delivery, governance oversight, and operationalisation of that model. I've asked Chris under the Transformation Improvement Board to work on an internal governance and assurance structure. So we've got more dovetailing into the board and our management groups and our executive team about delivery, risk management, kind of implications, impact, communications, engagement with teams. We've been doing that over a number of months. I just think it needs to be sharpened up for us, which we will do. We'll then talk about a bit more formality around the leadership responsibilities. I'm going to talk to the exec team about an exec lead for us playing into the system space. And once we get to a delivery plan, we can then bring that under our new arrangements to the board for oversight and assurance in terms of maintaining good services, ensuring we manage any risks effectively, but equally that we also take advantage of the opportunities that that central services approach leads to. The second point I will just raise is the focus of the relationship between the ICB and the Provider Collaborative Board is leading to a piece of work around recovery and transformation. There's been an ongoing dialogue about the role of an ICB for performance and assurance oversight, which they will inherit from NHS England, and also what we do around whole system and cross-system transformation programs, and the way that that infrastructure of PMO or performance oversight is established for resourcing. I've been asked by the PCB to be the executive lead alongside Maggie Oldham as the Deputy Chief Executive of the ICB to create a draft proposal. That's been circulated this morning. We will talk about it this afternoon to get some early insight from the board on that. I'm really pleased with how it's iterating. I think it's quite simple to follow, but we'll take a view of that this afternoon and get some feedback into that process. Yeah, the rest of my report is there for you.
And I take on board the penultimate sentence you gave there, which is we are discussing these in more details at the private board, so we don't need to replicate that here. But any questions to the Chief Exec on his partnership update? Thank you. Then we know the content of the report. Yeah. Okay, governance and assurance now. This is Director of Governance. Item 54, the niche external investigation summary report.
Thank you very much, Chair. So I'll take the report as read, but there were just about 5 or 6 things that I wanted to particularly draw your attention to. So the niche phase 5 report was published on the NHSE website on last Thursday at 10 a.m. That's obviously going to get discussed at Council of Governors on, I believe, the 11th of July. But the points in this paper are more about the sustainability. So we've gone through a series of phased reports with niche. We've gratefully received them, reflected on them, and that will be their last contribution to the organisation in respect of this piece of work. So it's beholden upon us to make sure that we maximise the taxpayers' money that's been invested in doing that piece of work and make sure that we embed and sustain all of the recommendations that they provided to us, because, as we've discussed before, they do not all exclusively pertain just to a urology service. So that's our commitment. This paper sets out, starting really on page 173, if you're following in the pack, a table that shows you where each recommendation is going to be overseen from. That doesn't mean that committee is going to be doing the work. That'll be with care groups, it'll be with the governance team, to make sure that we gather and tolerance test the evidence that those things are becoming part of our routine business in the organisation. There's at page 174, paragraph 14, there is reference to 2 recommendations, which we accept. We were a little bit disappointed as niche saw them, but nonetheless, both we have a work plan committee for both. In reference to recommendation 50, the company secretary is working with the chairman on progressing that, and with regards to recommendation 39, I'll be taking a paper to Quality Assurance Committee later this month that outlines how we form that work. And it's not to suggest that without recommendation 39 that there's some sort of desert of process. There isn't. There's all sorts of products that help us understand that picture. Safe Today reports, mortality reports, as well as a maturing IPR that's going to drill further into the body of the organisation to provide with that assurance. And then just finally, as Sarah referenced earlier, we'll be taking back a quarterly report to Quality Assurance Committee so that this doesn't disappear in the wind. It remains with us for some considerable time. Oh, sorry, one last thing. Just on that mapping exercise that you can see on page 173, we're going to write out to the chairs of the relevant committees, but I've paused doing that because I wanted to weld it together with the sustainability and embedding of CQC must-dos and should-dos. So we're doing one letter rather than people receive multiple letters. Thank you, Chair. Happy to take any questions.
Thank you. So basically, it's an update summary of where we are. We received the final niche report. We've indicated to us that we will continue to embed and continuity. There'll be a 3-monthly report that will be overseen by the quality subcommittee. A very good report, Richard. Thank you.
Sure.
Any comments on it? That's to note it. Okay, Richard, thank you. You check the paper. Okay, freedom to speak up annual report, Chief Nursing Officer, item 55. Tabitha.
Thank you, Chair. I am going to take the report as read. It is an annual report that is required to board. And also apologies that we're supposed to go to quality committee first, but because of our recovery support program, this was put on the plan to come to board for this month. However, in the future, I'm just making a note that when we have the annual report, it will go to quality first and then just for noting. So it's here for assurance in terms of the approach we are taking around freedom to speak up. And the fact that freedom to speak up activity is supported by myself and the non-executive director. We have monthly meetings with the Freedom to Speak Up Guardian to make sure that the approach and the activities we are doing are embedded in the principles of continuous improvement. It also outlines the activities over the year for 2022-23 in terms of where we are as an organization. And there are some 4 recommendations for board to note, which are, I'm not sure, because I've got a paper copy right at the end of the report. So it's here for assurance for board to note in terms of activities, and I'm happy to take any questions.
You've got Cara and Westminster Guardians are also on the call, Chair. Got it.
Yeah. Tabitha, do Cara and Wes need to add anything to what you said? I know they're here.
Yeah, they can do. If I've left anything, that's that what to highlight from the report.
It's not, it's people committee work plan rather than quality work plan, because I could see everybody going, oh, I think it's the other. So it's on the people committee work plan. Yeah.
Okay, right, thank you. Cara and Wes, you don't have to say anything to the board. Please don't feel you have to speak. But I'm just giving you the opportunity. Anything you want to add to Tabitha's feedback? Wes first.
Yeah, it's just to point out our recommendations to the board about the introduction of mandatory training for all staff, and the focus in the trust leadership training on speaking up has been welcomed improvement for UHNB staff in 2023, and we request that it continues. Our second recommendation to board is the Freedom to Speak Up Guardians requests support by the Business Intelligence and i3 for the continued development of meaningful and comprehensive data sets and dashboards for Freedom to Speak Up sharing learning across the trust. Recommendation 3, the Freedom to Speak Up Guardians need to report that there are pockets of senior leaders across the trust who feel that reaching out to Freedom to Speak Up service is a failure of their leadership, and it is not viewed as a positive action to support staff. We request support from the board to ensure that there is influence regarding the value of positive engagement with the Freedom to Speak Up service, which is a vital resource to support UHNB vision. This is a great place to be cared for and a great place to work. We request the Trust continue to develop tools and processes based on the principles of psychological safety, just learning and compassionate leadership. And recommendation 4, there has been many positive impacts of increasing our investment in the Freedom to Speak Up team with the addition of the 3rd Freedom to Speak Up Guardian in 2023. This move has increased the diversity of the team and given us capacity to reach out and work proactively with all groups, including those colleagues with protected characteristics. The Trust Survey in 2022 demonstrates the colleagues with protected characteristics feel less safe to speak up than any other groups. The current Freedom Speak Up team was established with 1.2 whole-time equivalent as part of the RSP improvement programme, responding to feedback from the MIAA audit, CQC and niche reports. A decision was made to increase the team by 1 whole-time equivalent during the cycle of improvement. To sustain and continue with the much needed work for Freedom Speak Up service, we request support for this resource to remain permanently within the team. Thank you.
Thanks, Wes. So if I can just bring the Chief Exec in, then just guide the board on these issues. Wes, this may disappoint you, but the board isn't empowered, and it's not the role of the board really to look at specific resources. They belong very strongly in the executive sphere of influence. You know, there is a danger that if we get requests coming to the board for staffing complements all over the board, one, we wouldn't be able to track it. Two, it dilutes our assurance role. That is clearly an executive role to deal with resources here. I'm going to propose that outside of the meeting that you and Tabitha work with the company secretary and bring to the board the recommendations within the board remit, and then take the requests for extra resources through the appropriate executive channels. And then we can just separate what the board is asked to recommend via the submission of the paper and what the executive team are asked to deal with through the submission of the paper. So it's just to guide the board in that direction. We are not empowered to uplift staffing or resources in that area, and it actually prevents them doing their role. We are not operational.
Okay, thank you.
Okay, thanks, Rose. Karen, you want to come in? Sarah, then.
Thank you, Mike. My question was really largely responded to by what you've just explained, but I guess behind that was just a concern as to whether it was a misunderstanding that was bringing these recommendations to board, or whether there was a sense of lack of support that was bringing these recommendations to board. So it was more, what's the root cause behind the recommendations coming here? And whichever it is, it's important distinction, I think.
I'll ask the chief nurse to look at that, please.
Yeah, I'll take it as an action. That's why I suppose Karen, yeah, I left it as take the recommendations as read.
Thank you. Okay.
Thank you.
Sarah?
Thank you. Really good to read the report, actually, and I think in terms of the data in it and the way it's moving forward, it's really positive to see. I had a question about the pie chart on page 61 in the reference pack, which is about the different issues raised through the service, and by far the largest group is called other inappropriate behaviours and attitudes, which must be not bullying and harassment, because that's done separately. And I just wondered if there's any more detail around that, because that's quite a large group, without really detail about what those issues might be and how they're being addressed.
I'm happy to take that, Chair, because we took freedom to speak up to the governors. And one thing that was pointed out is for us to strengthen our data and how we sort of elaborate on some of those. So we will work with your comment and sort of explain some of our charts. Though they're good, we need to sort of explore a bit further to sort of look at those groups. Where is it coming from? And the themes, take that on board.
Cara, can I just check with you? You want to come in?
Yes, sorry, just in support with what Tabitha was saying, that is the reason behind the asking for resources, because we are currently in the process of trying to sort out our data, just so our efforts are intentional and more targeted in terms of the recommendation that we're giving to other care groups and the board as well.
Fully understand, Cara. It's just a process and assurance and governance that I wish to follow. fully understand the reasoning for the request, but it belongs under the sphere of executive decisions, really.
Thank you very much for the clarification.
Chief Exec.
Yeah, thanks, Wes and Cara. I know if Heather was here as well, we'd be thanking Heather for her efforts. So it's just a reflection from me on the role and the value that the Freedom to Speak Up Guardians play. You can see it play out in the report. We see that every year. I've been really pleased, Cara, with your leadership as you've come into the team as well, and the kind of different way of thinking and the different access routes that gives some colleagues to come up and speak up. It's specifically recommendation 3 that I wanted to talk to. So I'll say here as Chief Executive, so any member of the leadership team, whether it's the exec team, the deputies or the care groups, the Freedom to Speak Up process is a valuable part of us learning more about what colleagues may be going through and having an issue with that needs dealing with. And regardless of how well we might think we lead teams, etc., there could be very many connotations of why someone doesn't feel comfortable in raising an issue directly with the leader. So I will have a very dim view of any leader that says, actually, I'd prefer you not to do it that way. I want you to come to me, because there'll be reasons underneath that. And we just need to kind of get over ourselves a little bit, because all ways of raising concerns should be celebrated. And whatever it is that we get through those channels, we should then do something with purposefully and proactively. So I just wanted to give real support, Cara, Wes, Heather, Tabitha, to recommendation 3 in particular.
Thank you. On that note, then, I'm going to ask colleagues to note the report, and then Tabitha will work with the company secretary to then just disengage the issues that need to go to the executive groups and then issues that the board would take. Colleagues happy if I take chair's action on the board? Yeah. Okay, thank you. Okay, then we'll move on. Wes,
Thanks, Wes.
Cara, thank you as always. Keep up the good work.
Thank you very much.
Thank you. Bye.
Bye. Thanks, Tabitha. Okay, item 56, NHS England submissions of annual self-declarations. Over to the company secretary.
Yeah, thanks, Mike. So we're authorised as a foundation trust by NHS England, and as an authorised provider, we're set up to operate and meet the requirements of the NHS provider licence. At the end of each financial year, the board is required to self-certify to the extent that it's met the provider licence requirements. The report gives details of the specific requirements, and we prepared a self-certification in the format that's mandated by NHS England. Now, when we entered the Recovery Support Programme and SOF 4, NHS England decided that there was sufficient evidence that the trust was not consistently meeting provider licence requirements. And board members will recall that a number of enforcement undertakings were attached to our provider licence. So on that basis, we're not going to be able to consistently self-certify that we meet all the requirements of the provider licence. What the report goes on to discuss and picks up the thread that Chris referred to earlier, we anticipate that as we progress to SOF 3, there is a verbal offer from NHS England that they will review those undertakings with a view to removing them. But we're not at that point yet, and therefore we have to report on the last financial year when the undertakings were in, and therefore you'll see that there are a number of areas where we've said not compliant with the requirements. The report gives an overview of actions that have been taken and sets out a couple of areas of risks and mitigations that need to be followed through in this next phase of our work. But other than that, Mike, I'll commend the report and ask for board support in publishing that self-certification on the website.
Straightforward, colleagues. Yeah, happy to endorse. Thank you. Thank you, company secretary. Okay, policy and publication reports. You've got it in front of you. The one on car parking is guidance, so there is a tag to the policy. I'd recommend you go to the policy, because in the guidance papers it says things like we propose and we suggest, and that's not what the policy says. So go to the policy for clarity, really. But nothing from those papers. Okay, you've got the attendance monitoring register, schedule of business, no urgent business brought to our attention. I'll close then the board in public at 12:20. Colleagues, we reconvene again for the private board. Are you okay at 1 o'clock? 40 minutes. Great. Thank you. Thank you for those on Teams. Good to see you. I hope you did hear most of it. See you all soon.
Yes, thank you, Chair. Thank you.
Yeah, thank you.
Min, I always ask